Hello, my name is Omar Lira-Gomez. This is Respiratory Care 443 of Spring 2025. I will go over lung ultrasound in relation to mechanical ventilation applications. Let's get started. Some objectives for today are to describe the diaphragm physiology concerning lung ultrasound, explain the purpose of lung ultrasound for mechanical ventilation, describe the purpose of lung ultrasound for airway management, and to describe ultrasonography in the process of weaning from mechanical ventilation, and to discuss the role of the respiratory therapist regarding lung ultrasound technology. The diaphragm. The diaphragm is a primary inspiratory muscle. It plays a significant role as the primary inspiratory muscle involving breathing. It is no secret in the respiratory community that the diaphragm muscle is used during inspiration and is passive at expiration. It accounts for 75% of ventilation at rest. Diaphragmatic dysfunction is a predictor of poor patient outcome in the ICU. Mechanical ventilation, sedation, and bed immobility can lead to diaphragmatic dysfunction. The lung ultrasound can assess the size and function of the diaphragm under mechanical ventilation, however, has only recently been introduced to assess the size and function of the diaphragm. Diaphragmatic dysfunction can be caused by several factors under mechanical ventilation in the ICU. There are four kinds of myotrauma from mechanical ventilation in what is known as ventilator over assistance or excessive unloading. And there is also excessive and expiratory shortening. There's eccentric muscle contraction, insufficient mechanical ventilation settings or unloading that can lead to diaphragmatic injury or myotrauma or diaphragmatic atrophy. In addition, sedation, medication, malnutrition, shock, electrolyte imbalances, and sepsis can all lead to what is known as critical illness associated with diaphragmatic weakness. Diaphragmatic thickness can be used to assess inspiratory function as it is closely linked to dysfunction of the diaphragm. Diaphragmatic thickness is measured at the end of inspiration, at the end of expiration. Diaphragmatic thickness fraction can be calculated using the difference between diaphragmatic thickness at inspiration and diaphragmatic thickness at expiration divided by diaphragmatic thickness at expiration multiplied by 100. Lung ultrasound can be used to assess changes in the diaphragm thickness as it contracts. This can aid in predicting extubation success or failure. Diaphragmatic excursion can only be used during a spontaneous breathing trial as another unit of measurement for diaphragmatic weakness. Studies have shown that diaphragmatic excursion of 1 to 1.5 centimeters and a diaphragmatic thickness fraction of 30 to 36% are predictive values for successful extubation. Using B mode under lung ultrasound can be used to assess the pleural line it is easily visualized in what is known as the bat sign. It can be used to diagnose several cardiopulmonary disorders. Using M mode, it is possible to identify inspiratory muscle contraction and therefore measure the thickness of the diaphragm. Applications of lung ultrasound on mechanical ventilation. I will go over what is known as the blue protocol. It is frequently used for diagnosis of pulmonary pathologies in critically ill patients. Lung ultrasound can predict patient readiness for weaning. Lung ultrasound in the ICU can decrease the time of ultrasound to extubation in patients with normal functioning lung diaphragm. Lung ultrasound can be used in airway management, in PEEP titration, and in disease diagnostics. The Blue protocol is the bedside lung ultrasound and emergency protocol, a score ranging from 0 to 36 that accounts for all lung regions. There are 12 thoracic regions in the lung. After a spontaneous breathing trial, a lung ultrasound score of less than 13 is highly predictive of extubation success. A score of greater than 17 is highly predictive of failure. There is a positive correlation between lung ultrasound score and improved lung gas volume. Lung ultrasound scores can predict non-invasive respiratory failure in neonates affected by respiratory distress syndrome that can lead to preemptive surfactant therapy. As we can see here in the image provided, a score of 0 indicates a normally aerated lung. A score of 1 is a moderate decrease in lung tissue aeration. A score of 2 indicates a severe decrease in lung tissue aeration. And finally, a score of 3, which is the highest score you can receive in a lung region, indicates a total loss of tissue aeration. As we can see here in the images, progressive sound waves are seen here in the score of 0, whereas the score of 3, we can see that sound waves are not able to travel as freely as in the score of 1. Titrating PEEP settings. PEEP remains one of the most difficult parameters to set. Both setting it too low or too high can have detrimental effects on patients under mechanical ventilation. Increasing PEEP can lead to the recruitment of lung tissue, which is observable on lung ultrasound as smaller constellation when PEEP is raised from 5 on the left to 15 on the right. As we can see here, sound waves are not able to travel as freely here with a PEEP of 5, whereas a PEEP of 15, we can see sound waves traveling more freely, indicating more aerated lung, indicating recruitment of the lung, which is then a positive correlation to proper PEEP settings under mechanical ventilation. Lung ultrasound airway management can be used to assess in the assessment of laryngeal tracheal injuries such as edema, stenosis, and stridor, which can then lead to prediction of difficult intubations or post-extubation stridor. It can also be used to visualize endotracheal intubation and esophageal intubation. Lung ultrasound can be used to guide mechanical ventilation settings, PEEP, and lung recruitment maneuvers. Lung ultrasound can be a key tool in early diagnosis of the most common complications of mechanical ventilation. Diagnostics. Lung ultrasound confirms a pneumothorax with a specificity of 100%. A Shred sign is seen following a pulmonary infarction. COPD and asthma suspicious present with a profile on lung ultrasound. Pulmonary edema presents with multiple diffuse bilateral B lines and regular thin pleural. Pneumonia can present with a unilateral B profile, a bilateral B profile, a C profile, and/or consolidation with dynamic air bronchograms. Studies have shown that lung ultrasound can accurately differentiate between cardiogenic and non-cardiogenic pulmonary edema. It is a valid tool for effusion drainage and monitoring. The biggest benefit of diagnostics with using lung ultrasound is that it can be done bedside. It requires no patient transfer. It requires no harmful radiation to the patient, which is the biggest benefit when compared to CT imaging. Respiratory therapists can be trained, and studies have shown that RTs are trained independently, capable of performing lung ultrasound with an accuracy of greater than 95%. Studies suggest that the performance of lung ultrasound should be extended to other healthcare professionals that are other than doctors. RTs possess the knowledge, skills, and the ability to provide a wide range of diagnostic and therapeutic procedures for cardiopulmonary disorders. RTs have the proper knowledge to navigate lung architecture and the knowledge and are knowledgeable in various cardiopulmonary disorders. In addition, RT-driven protocols have resulted in shorter weaning times, increased extubation rates, and increased ventilator-free days. Some limitations of lung ultrasound include operator dependence, subcutaneous emphysema, large psoriatic dressings, and obesity can all limit lung ultrasound sound waves from transmitting through lung tissue and then into the lung. And the biggest drawback is lung ultrasound cannot detect alveolar overdistension or hyperinflation. However, several studies are looking into this to hopefully someday figure out how to detect overdistension using lung ultrasound. Here are my references. Thank you so much.